Welcome to the Telehealth and Medicine Today Journal unscripted podcast series where research and innovation collide. Today's topic is the real economics of value-based care, featuring Erik Johnson, Optum Senior Vice President and National Practice Lead for Value-Based Care, and Dr. Lyle Berkowitz, Founder and Chairman of KeyCare and Editor-in-Chief of Telehealth and Medicine Today. Let's get started.
Welcome to Telehealth and Medicine Today's unscripted podcast series. This is Lyle Berkowitz. I am going to be the host today, and the topic is value-based care. What does this really mean? It is something we talk about all the time as the way to solve our healthcare system, and yet it has created a lot of questions. And today we have an expert who's going to help walk through some of the answers to those. Erik, expert in value-based care, has worked in multiple organizations in these roles, and I'm going to ask him to introduce himself and give some background on why and how he's gotten involved in value-based care and what his expertise has been. Erik?
Great. Thanks, Lyle. I'm Erik Johnson. I'm the Senior Vice President at Optum Advisory Services, part of United Health Group. I run the payer strategy and value-based care practices there. I've been doing that for about 11 years, and I've been in value-based care engagements since about 2007, 2008, when Dartmouth-Hitchcock initially started to propagate the ACO model. I've been in healthcare for about 35 years, started at the Office of Management and Budget as a civil servant, as a Medicare budget examiner. So pleasure to be on the podcast today.
Great. So Erik, when we think about value-based care, two big questions come up that I want to make sure we get to today. So the first part is we're going to talk about how do these contracts actually pay? And the second is, who is really the winner, the loser, who's subsidizing, who's paying them. But let's start with how do they actually pay? So walk us through what really happens in value-based care. How many are these truly full risk, capitated contracts, what we used to think of as HMOs, versus some more partial glorified pay for performance with the majority still fee for service?
Sure. It's a great question. And I think it's one that's clarifying in any of these conversations or any of the conversations I have with clients. Because you can mean a lot of different things with value-based care. If you think of the sort of the distribution curve of value-based contracts, at the far right, at the tail of that would be what you describe as full capitation. I'd say about 10 to 15% of healthcare providers in the country today are covered under at least one capitated contract that they have with the payer. That includes Kaiser Permanente, which is a big chunk of that 10 to 15%, but there are others that are out there. And there are more today than there were, say, 5 years ago. And I'm really relying on the HCLAN data for sort of this sort of distribution, understanding the distribution. Middle of the curve, I'd say that about 50 to 60% of providers in the country are in what we would call a shared savings model. Dartmouth-Hitchcock started that intellectual exercise back in the late aughts. CMS adapted it. CMMI adapted it in the wake of the ACA and what we would call accountable care organizations, which sort of limit the risk corridor for participating providers. So they see a bit of what I would say a surplus gain if they're able to reduce expenditures under a benchmark, and they share in some of the losses if they exceed that benchmark. But they don't have full, what I would call insurance risk on the lives that they have been either attributed or assigned. That gets you to about 70%, 75% of providers in the country. The remaining 25%, sort of more that left side of the distribution curve, are in, for the most part, something like pay for performance or pay for quality, where there isn't a real focus on utilization as there are in the other two models, but more of a focus on procedure and quality. Depending on who you ask, those count as value-based contracts. There's certainly value being delivered. but it wouldn't be value based on what I would call actuarial risk.
So, yeah, the next question is, so how are they working, and which one do you think makes the most sense? It can take more time, right, to manage these patients. There's care coordinators you might have to have, extra time with complex patients, trying to keep them out of the ER, etc. Is anyone actually winning? Are these doing what they're supposed to do? Meaning, are they decreasing the cost of care by providing higher quality outpatient care? And are payers or providers, I should say, individual providers, large health systems, are they actually winning? And can you walk us through what that looks like?
Sure. They all work. They don't all work in every case. And it does sort of depend on a couple of things. One is, what are you trying to accomplish? So if you're really trying to accomplish an increase in, say, quality scores or length of stay reduction, like a bundled payment program might be seeking to accomplish, I think we've got pretty good evidence that you can achieve those things. If you're seeking to manage the population at large, moving away from sort of what I would call episodic risk, moving more into total cost of care risk, there are models out there that work. And I think they have demonstrated some best practices that can be adapted across the industry, but they don't work in every instance. And I think some of the areas where these things fail, some of the Achilles heels where these things fail are, I would list it in three big buckets. One is they're not operating at scale. I think what we have seen is that these are scale models. An insurance company is a scale model. And really what we're talking about here is reassigning insurance risk from an insurance company to a set of participating providers. Insurance companies will tell you that you need a lot of people in a particular insurance product in order to have a normalized risk distribution. So I think when we see providers trying to do this with fewer than 5,000 lives, it becomes really tricky. This is a scale-based model. I think the second area where these things fail is they haven't priced the risk correctly. And that is a challenge that a lot of actuaries are out there trying to solve right now, working very hard at solving for it. We have the most experience in the Medicare population, given the preponderance of ACO models within the Medicare population. So we have a pretty good understanding of what the over 65 population risk profile looks like. But once you get into Medicaid or commercial lives, it gets much harder, I think. But the third area is the biggest area of biggest point of failure, I think, in these models. And that is institutions and integrated delivery systems are unwilling to commit. This is hard. It is hard to do this well. And it is the development of a different set of muscle skills, muscle memory for a health system that has traditionally relied on volume to drive the economic success of the enterprise. I think in the long run, value-based care can be more profitable to a healthcare system, and we can get into that in a little bit. But it is a very different set of economics that you're working with. And what we have seen, I think, over the last dozen years or so, is a willingness to experiment with these models with isolated populations, but not a willingness to expand the experiment to all populations covered. And that's really critical. I think because it is such a scale-based model, you need everybody sort of rowing in the same direction for all of your patients. And without sort of that organizational long-run commitment, these things tend to wither on the vine.
So I always find that one way to get people to change is to show them someone who's done it and has been wildly successful, right? The concept of I'll have what she's having. Who do you point to? What outside of the Kaisers of the world, which are just huge. When we're talking to a 50-person medical group or even a regular sized health system, are you able to point to someone and say, look, if you take this contract, you can double your net profit or something. Are there enough big wins out there that you can point to someone, either a medical group or a health system, and say, look, these guys did commit, and the result were not only better quality, but also significant financial returns?
Yeah, I think there are some that are out there, and I think they're all relatively illustrative of the commitment that you need to make and the intentionality with which you need to pursue these things. UNC healthcare system in Chapel Hill, but greater part of central and northern North Carolina, I think have been on a 12, 13-year journey in getting this right, and have seen significant returns to the health system. Ochsner has done this, I think, pretty well. Bellin has done this pretty well as integrated health systems. When you move into sort of physician groups, I think we have seen it's easier to do with physician groups, and I'll talk about why in a second, but not that it's easy, but it's easier. Certainly, the sister company from Optum Insight, where I work, Optum Care, has had some pretty significant success in both the commercial populations as well as the Medicare populations over time. So I think there are lessons out there, but I think the lessons, it's calculus. It's not addition. I think that these are hard lessons to learn. And again, I go back to UNC, for example, who's been on a 12 or 13-year journey in all of this, being very deliberate in how much risk they're willing to take on with their populations over time and how sort of methodically they've expanded their exposure to that risk. I think it's a great lesson. You mentioned Kaiser as sort of the example not to use, and I'm glad you said that, because a lot of health systems, a lot of integrated delivery networks that I talked to have asked over years, how do we be like Kaiser? And I think that's the wrong question. Kaiser has been doing this for 80 years, 85 years. It got started in the shipyards of the East Bay in California during World War II. And it was really an effort to keep employees healthy and productive in building warships. That's an 85-year span of culture and inoculation that is very difficult to replicate in any other system. Some have tried, and some have done a relatively good facsimile of it. But Kaiser is not the model to replicate. The things that Kaiser has done that I think are illustrative and instructive for what other health systems need to do is they have really invested in their primary care and ambulatory footprint. I think community-based hospitals or academic facilities that do not have a commensurate ambulatory and primary care footprint are going to struggle with this. I think that's one of the things that we've learned. It's difficult to do this by yourself. And as a community hospital or as sort of a multi-hospital system, you also have a tremendous amount of invested in stranded capital that you need to amortize. And that is very difficult to do if you don't have a lot of lives who you can run through those capital investments while at the same time managing their care over the continuum. So it's tough. Yeah, it's not widely adapted at successful scale at this point, but I think there are enough different types of health systems and physician groups that are out there that have done this to demonstrate that it can be done in different types of environments and different types of markets.
If you look at those, Erik, I'm curious if you do think that how much of it is people, process, technology, culture, etc. Like, what are there commonalities amongst the winners that are more clear, and or is it the tipping point somewhere, right? We'll often talk about, it's got to be at least 30, 40, 50, 60% value-based care before you really see an organization embrace it. What do you think are the commonalities amongst the folks who are doing well?
Yeah, I think it's a combination of those two things. It's a combination of sort of the art and science. I think the science is what you were just describing. I am not an actuary, but I work a lot with our actuarial leaders within Optum Advisory. Hat tip to them if they're listening. And I think what they have determined, and makes sense to me, is about 35 to 40% of the primary care physicians panel of lives. Let's say it's 2,000 lives. If you've got 800 to 900 lives under some element of actuarial risk, that's enough to shift practice patterns to manage those populations in a more value-based longitudinal way. So that's kind of the science of it. And that should be backed up with other science, good analytics, the ability to risk stratify the population, the ability to dynamically schedule people to come in if they weren't otherwise scheduled in order to reconcile their meds, or you've noticed that there's an emergent risk factor that needs to be addressed. Otherwise, they're going to end up in the emergency room. All of that can be done in really, really good and really available analytic platforms. So there is a lot of science there. But I think the art of all of this, sort of alluded to this earlier, is sort of the organizational commitment to this. And I think one of the examples that we often think about and talk about with our clients is the sort of the instinct for health systems who want to do this to start their own health plan. And that's a dynamic that goes back 30, 40 years, right? And what we've seen over the last 30, 40 years is a lot of health systems start their own health plan and give up a couple of years later. And they give up because they've enrolled 700, 800 lives. They've got a lot of stranded capital there to meet state capital requirements in order to back up any sort of claims overrun. It's just not worth it to them. They give up their license, they give up the insurance products. And I understand why they do that. But I also understand that this is a long-term objective, right? This is not an 18-month strategy. This is a 3 to 5 year strategy. And in the insurance, provider-sponsored health insurance example, we don't recommend that as a default strategy in every case. But if a health system wants to do that, we do like to warn them, you need to be aware that this is a 7 and 9 year bet. You're going to take a very slow growth curve over the first couple of years because, frankly, consumers and businesses aren't going to be familiar with your insurance product. That's what we call the broker lag. You need to really make sure that you're working the broker channels in order to build up the membership base that you need in order to successfully manage lives under an insurance risk framework. I think the same sort of mindset is true even if you're not starting your own health plan, but you want to take delegated risk on these lives. You need to think about it in terms of 5 to 7 years. You're going to learn a lot in the first few years. You're going to tweak the analytics. You're going to tweak your ambulatory care network. There's a big change management process that goes on in the practices themselves. There's a big change management practice that goes on within hospital discharge practices. These things take time. I think it's worth it if you're willing to make that bet. But I always want people to be aware of how big of a bet they're making.
I always worry that a lot of large medical centers are victims of their own success. They're doing wildly successful numbers in a fee-for-service volume-based business, and it is hard to make that change. And we'll talk a little more about where that organizational commitment might focus. But I want to ask another question based on my experience as a primary care doc who in the 1990s, when HMOs capitated were around 40% of our population, we handled those patients a bit differently. For example, we offered them phone-based virtual care much more readily because we didn't make any money by having them come into the office. So the funny thing is, what we call concierge care today, which is a lot of phone-based care, so you don't have to come in, makes me reminiscent of 1990s HMO care in many ways. And yet today, telehealth, which is something I'm very involved in, struggles to get as much acceptance and adoption. And I think part of that is because traditionally it's been because we didn't pay for it, but we with the COVID rules now we're paying for it, often equal to office-based care, and we've seen a rise. But I'm curious your thoughts on how and why that isn't even adopted more, because it's been shown to reduce ER visits, etc. And additionally, we'll comment on how and why do we pay primary care doctors more to be the front line to help reduce some of the later high-cost care, whether that's done via pushing for more virtual care or other other actions. So threw a couple of things at you around
Sure.
compensation of telehealth in general, primary care specifically.
Yeah, I'll take I'll take the telehealth question first, because it's a great question. And one of the things that I think has been a real lost opportunity is all of the things we learned during COVID that worked, that were different. And I think telehealth is one of them. I think we learned a lot about how effective telehealth could be in managing sort of low risk, but not zero risk patient lives. Um, Telehealth spiked, in April of 2020. By the time we get to October of 2022, we're a little bit above where we were in October of 2019, but we've sort of given up all of the progress we made in telehealth. Some of that's policy driven. I do think that we're probably going to see Medicare. Medicare sort of sets the tone for everything. If Medicare chooses to pay for something, it eventually gets paid for. And I think if we can get to sort of policy stability in Medicare around paying for telehealth, at least there will be a rate. There'll be a fee schedule associated with it. We still need to drive adoption in the management practice. And I certainly understand why patients and doctors want to see each other physically, but I do think it was a lost opportunity in COVID to sort of hardwire that into the practice of medicine. And I think part of that was cultural, and I think part of that was regulatory. And I would love to see it come back as not because of a pandemic necessarily, but because that there is a differential reimbursement attached to telehealth, particularly for primary care, who are the first line in all of this. So I think that is something that again, I think is a tremendous lost opportunity. I think we know pretty well at this point, based on Kaiser experience and other experience, what works with primary care. I think the challenge is in getting adoption. And I'm always reminded of a story of a primary care physician who sat on the board of a health system that I was working with. And he came up to me at a board retreat and said, "So you're the guy who's going to move me to value-based care." And I've had that conversation 1,000 times with physicians, and it's never gone particularly well. And I said, "Well, we'll see, depends on the analytics." And I was sort of going through my rationalization for the work. And he said, "Well, if you could do it as fast as possible, that would be great." And I was stunned at that response, happily stunned. But I sort of said, no physician has ever said it to me. "Why are you saying that to me?" He said, "Well, I would love just to be able to see the patients and talk to the patients who I really need to see. Because right now what I'm doing in the fee-for-service world is my office staff is just dialing all week to fill my schedule with patients who are on my panel, but I may not necessarily need to see. If I could instead get them to dial the patients who do need to see, otherwise they're going to get sick and end up in the hospital, or they're going to go off their meds and have some adverse reactions and adverse consequences, then I'd be practicing much better medicine if I could do that way." And I thought that was a really astute observation, that got more to the culture of medicine, and I'm not a physician, that I'm able to get to. I sort of speak in contract and finance, and he was speaking in terms of clinical practice and why value-based care made sense to him that way. Now, I think concierge medicine, when it initially sort of was a boomlet in the early aughts, was partially in response to physician frustration in primary care, with that dynamic, having to dial for dollars all the time. For whatever reason, concierge medicine has sort of ebbed and flowed over the years. It's never really caught on at scale. And I think value-based contracting is an opportunity to create the same dynamic, as long as we're paying the primary care docs for sort of what I call managing the life. And one of the things that I think people miss in the value-based care debate is we're not inventing any new risk here. The risk, if we're going to have third-party insurance, we're going to have actuarial risk. Historically, insurance companies have managed that not particularly well, and for reasons that I'm more than happy to get into. Value-based care is an effort to take that existing risk and reassign the responsibility for managing it to somebody else. Primary care docs have the broadest purview of what their patients need. probably have a better way to anticipate what those needs might look like in 6 months, given their history, and plot a path of care that can keep them out of the hospital, keep them healthy. And like, we should be paying them for that value. And, I'm not sure the RVUs do that. But I think, a PMPM sufficiently priced does. So that's kind of, I think, one of the math challenges that we have is getting that PMPM right.
When
Long
people
answer.
have asked, oh, keep going.
No, just a long answer to your question. Thank you.
So when people have asked me what's the biggest barrier to innovation at health systems and transformation, I'll often say it's actually how we compensate our physicians. That when you pay your physicians an RVU volume-based model, you're going to get that. And the way to game that system is the primary care doc is to see as many low risk type of patients as possible. And anyone who's high risk, highly complex, send them to the ER, send them to a specialist, etc. Because I can see a higher volume of these low risk patients. I can do a level 3, maybe squeeze a level 4 out of it, etc. But I'm starting to see some innovative health systems saying, hey, whether we have fee for service or value based care, we're going to pay our doctors based on panel size and panel size management rather than individual RVUs. And by doing so, we're going to encourage them to adopt technology, adopt extra staff and care coordination, and think about the bigger picture. I would love to see that more. I've only seen it a little. I'm curious if and how you've seen that. And even in a capitated world, yeah, when I see health systems paying doctors on RVUs, it's maddening. I'm curious what you've seen out there, and when you go in, if and how you in your role give advice on thinking about how to pay doctors differently, and the impact that would have.
Yeah, it's a great question. And I want to be careful here because I'm not a physician. And I think this is starting to get into how do we reorient the practice of medicine. And I'm not sure I have a ton of credibility on that question as a non-doc, but I can tell you what I've seen, and what we've increasingly seen over the last sort of the post-pandemic period, from 22 onwards. To your point about physician panels, and this may just be anecdotal, but a lot of the clients that I've worked with, a lot of the health systems that I may not be working with now, but I remain in touch with their physician leadership and the medical group leadership. A couple of things have popped. One is that primary care panels are getting smaller, particularly for employed or foundation-based practices, who may be largely relying on salary for income as opposed to volume. Now, generally, I'd say that's good, right? We're getting away from volume, but if we're moving into salary, then we're moving into something that might provide incentives to have smaller panels. And when we have smaller panels, physicians don't work as much under the existing comp models because they don't have as many visits that they need to pay attention to. That makes sense. However, what ends up happening is when a patient needs to be seen at 4:00 in the afternoon on a Thursday, either the physician may not be having office hours at that point, or they get referred to your point, to the emergency room, which is a much more expensive site of care, even if they're not really any sort of candidate for an inpatient admission. So those smaller panels have decreased, not in the RVU point of view, but they've decreased primary care productivity in the way that panels are managed. And I think that's a challenge that we need to get some insight into how we reverse that trend. I think the second thing we have seen over the last few years, and I'm sort of just repeating what physician leaders have told me, is that the default decision-making now, again, to your point, is not to take complex cases in the office, either to send them to urgent care or to send them to the emergency room. Not because the physicians are lazy per se, it's just sort of that's the decision-making that has been instilled in them in their recent training. And that's something that they're trying to overcome as well. So I think when we think about the practice of primary care, I think we probably I don't think as an industry we've done a good job of figuring out what productivity means there outside of the RVU framework. If we're thinking about it in terms of total cost of care, I think we can come up with some pretty good metrics to measure productivity, but we're sort of now betwixt and between. And so we're not giving physician groups a good alternative to the RVU model. We're giving them alternatives, but those are alternatives that aren't necessarily driving better outcomes or better management of costs.
Like I said, I think it's one of the issues that we have to face is how we pay these doctors and whether or not uh, the system is fully capitated, fully fee for service. To me, it's one of the great problems that we have, and has been a difficult one. But I think as a primary care doc, we would see dramatic changes because, as they say, incentives matter, whether you think they do or not, and we part of the work of value-based care has got to be how we reward the doctors appropriately for doing that better job.
Yeah.
And we'll talk a little more about some specifics on that later. The other thing I want to just finish on this sort of, does value care actually work? Where do you see the next 5 to 10 years? Do you see a slow, gradual evolution, an explosion? What do you think is going to happen with our payment system? Because one of our biggest problems, I've taught a course before to med students, is not that we simply that, oh, we need all value-based care, but the fact that we have so many divergent systems, and it's very hard for anyone to optimize when you've got, a fee-for-service system, a partial value-based system, a full value-based system, etc. That there are just too many things going on to juggle it. What do you think is going to happen over the next, say, 5 to 10 years?
Oof, it's a big question. It deserves a big answer. I actually think we are at an inflection point with value-based care, and it could go either way. I think let's call it the second generation of value-based care that sort of emerged out of the ACO models from CMS, and in parallel to the growth in Medicare Advantage, have maybe run out of steam a little bit. And I think there is sort of this existential concern that value-based care has sort of exhausted its goodwill with the healthcare community. It's exhausted its economic potential with the healthcare community. Maybe we just need to find something different on a fee-for-service chassis. There's another group of thought that says we haven't gone far enough. I think you see that in the leadership at CMMI right now, that we need to go farther, we need to go harder, we need to go faster in putting providers at actuarial risk for the populations that, again, are either attributed or assigned to them. And I think CMMI in particular, has been consistent across administrations and across party affiliation in saying by 2030, we want every Medicare beneficiary in a risk-bearing model, whether that's MA or fairly aggressive ACO models. And I said earlier that Medicare does sort of set the tone for evolution in healthcare. I still believe that. I think the biggest reason we're at this inflection point is V28 and the changes in the coding rules for Medicare Advantage patients. And I'm not here to defend or attack the coding rules or V28 for that matter, but it did change the economics of MA quite a bit. And a lot of the success, quote unquote, success of value-based contracting in Medicare Advantage was premised on the ability to code patients really aggressively. And those were the rules. And I don't believe anybody really did anything wrong. They were just being aggressively adherent to those rules. When V28 took away some of the revenue opportunity in MA, there wasn't a plan B. And I think that, again, as much as COVID was a lost opportunity, I think the ability to, over the last 12 years or so, 13 years, to code aggressively gave the healthcare world an opportunity to learn how to manage care better. And I think what we learned was we learned how to code care better. And So when some of the opportunity or the arbitrage opportunity in coding went away, we hadn't invested in care models or population health models that would actually take utilization out of the system, that would actually prevent a lot of ambulatory sensitive or inpatient preference conditions out of the inpatient stay. We didn't invest in the systems that gave a lot of primary care doctors visibility, longitudinal visibility on what their patients required. So now we're at this inflection point. If value-based care is going to succeed, we have to get better at managing care, not coding care. We really have to be very focused in our investments on how we redesign care models to manage people in their community and outside of intensive care settings. Whether we do that or not is going to be probably the single biggest variable in determining whether value-based care has a sustainable footing going forward. I'm an optimist about that, but I don't think I'm Pollyannish about it either. I think this is going to be hard. I think it is going to require payers and providers to sort of rethink this. And I used to have a good-natured argument with a colleague of mine here at Optum. He was from the payer side, and he said value-based care is a payer problem. And my point of view has always been it's a provider problem. And I think we eventually came to the conclusion that it's a problem for both, right? And it's not that value-based care is a problem, right? It's that healthcare spending is a problem. And we need to figure out a way to better manage healthcare spending. Fee-for-service clearly is not the chassis on which we were able to do that. Value-based care is sort of the next logical way to think about doing that. And if there are better ways, I'm more than open to that, but I haven't thought of one yet. I haven't seen one yet. I think payers and providers have got to collaborate on this. Health systems are not going to solve this. We know that payers can't by themselves. It needs to be a collaboration between the two. And I think it really is going to be focused on designing, supporting, and paying for care models that enable providers to manage the lives in their community. The long answer to your question. I'm hopeful, I guess, on the future of value-based care, but I'm not naive about it either. I think there's a lot of cynicism out there about it right now, and I understand where it's coming from.
It's tough because it's one of those things where we feel like we've been on the verge for a long time. I mean, it's the right thing to do, but we've got to figure out all the dynamics. So let's jump into what I'll call part two, which is sort of specifically, how does this look in terms of winning, losing, subsidizing let's start with large health systems. So let's give an example. So if I've got a health system and I make $50,000 on the hip replacement, but in a value-based world, I want to avoid hip replacements. I'm willing to pay for care coordinators, do a variety of things to avoid 100 surgeries a year. That saves $5 million in costs, but also it costs me as a health system $5 million in revenue, plus the cost of actually doing the work to avoid the care. Walk us through it. How is that actually replaced? Like, what are the economics where it makes sense for me as a health system who makes a lot of money on these procedures to spend and ER visits, et cetera, to spend a lot of money to lose money? Because that's what it feels like. That's the counter argument to why would we ever do this? What are the numbers that have to happen to convert a organization?
Yeah, it gets at some really hard truths about healthcare. And again, I go back to the premise of value-based care, and this is the premise that I believe. People will disagree with this, and I acknowledge that there's a legitimate counter argument to this. But my point of view, and the reason I think value-based care got as much attention and continues to get as much attention as it has, is that we spend too much money on healthcare. So what kind of equitable incentives can we put in place to sort of rebalance and reoptimize the allocation of resources to healthcare consumption in the United States? That's a broad, grand statement. I acknowledge that. But that's the fundamental premise. We spend too much, but we don't want to sacrifice quality. We don't want to sacrifice access to the people who need it. So how do we realign incentives? I think that's the first premise. The second premise then is, how do we realign supply and demand? And this is where it gets hard, right? To your point about hip replacements, for example. There's probably too many hip replacements in the country. Writ large, right? There are access issues and population issues, and I acknowledge that. But if we were just to take a per capita count of how many hip replacements there are in the country, we probably could all agree that there are probably too many. The question then is who's going to continue to do them and who's not going to continue to do them? And this is one of the hard truths of value-based care is that there are losers in all of this. There are winners and there are losers. And the winners are going to be defined by two things, I think, particularly from a health system standpoint. The first is, are you able to do those procedures as efficiently as possible? And are you going to be able to do more of them than your competitor in the marketplace? And your competitor in the marketplace then is either going to lose money on ortho or they're not going to do ortho anymore. When I talk to a client, when I talk to a health system client or an orthopedic groups or whatever, they want to be the winners in all of this, which is great. But it is not necessarily going to be a rising tide lifts all boats scenario. I think there are going to be health systems that are either going to shut down service lines and reposition those resources to other types of patients and specialties, or they're going to close whole wings. I think, I go back and forth on whether we have too many hospital beds in this country or not. Right now, hospitals are pretty full. They're full with medical patients, not as many surgical and procedural patients. But in certain communities, there will be fewer hospital beds if value-based care succeeds, because we are keeping people out of hospital beds, and the hospitals that aren't good at managing the care, not good at managing the lives, are going to lose. So that's the first thing I would say. The second thing I would say, and I've had this conversation with a friend of mine who runs a health system in Eastern United States, and he's a hospital administrator, born and bred, one of the best ones I've ever met. Brilliant guy. And he was asking me the same question: why should I do this? Like, I make money on admissions. I've got a big primary care and ambulatory footprint, but I don't know why I should do this. And my question to him, and it was an honest question, I wasn't leading the witness. I said, what would you rather have? The marginal DRG payment or the marginal premium payment? That's a somewhat stark contrast. And he looked at me and he said, that's a really good question. From a margin standpoint, I'm not sure. And I said, well, that's a math question, Mark. We can figure that out. But if the premium payment is more profitable to you than the incremental hip replacement, then maybe the economics of the health system should change. And so we did that work with him. So I think that's kind of the question those are the questions that we need to confront, right? Who's going to lose in all of this? And if you're one of the health systems or provider groups thinking about going into value-based contracting, you don't want to be one of the losers. How do you win? That's going to require a whole lot of change. And if you're a health system, how do you need to rethink the economics of the income statement of the balance sheet? It's not an income statement for most hospitals, but how do you think about your margin statement and your balance sheet in light of these types of economics? And let's just do the hard work of the math to figure out what makes most sense, because that will determine whether you have a good shot of being a winner or a loser in these new types of contracting models. That's a health system standpoint. It doesn't get to the physicians that are doing those procedures, but I think the same general principle holds true, particularly for large multi-specialty physician groups.
And so if we look at those big groups here, a lot of attention these days, and I'd argue success, seems to be around the MA plans, right? If you can, the Oak Street Healths of the world, if you can, collect $10,000-$20,000 a year on a PMPM and have enough patients, you can really have the money to spend on delivering better care, getting better outcomes. Is that our lighthouse? Is that what we should be focusing on? Because MA patients, by definition, older, going to have more expensive issues. It allows the money to be spent in the outpatient arena without necessarily having the hospital complaining about less procedures. What's your take on MA, and is that going to get bigger? Is it going to explode? Is it just going to be flat?
I think the Oak Streets, ChenMeds, OptumCare, I mean, they're all having their issues right now because of the V28 issues we talked about earlier. But I think in the medium to long run, I think you're right. I think those are good models that have a lot of potential and give me a lot of hope that this circle can be squared. I think, though, I don't think it's a short-term issue anymore. I think it's a medium term. I think Medicare Advantage, we're sort of in the pause, if you will, in the MA growth curve. We've seen it's really interesting what we saw during annual enrollment last fall. We saw a lot of MA plans leave certain markets because the funding levels probably weren't to their liking, and I understand that. What we also saw was a real resurgence in HMO products in those markets, replacing PPO and open network products, because I think those plans want to create a little bit more control over their membership. And those HMO products the bedrock of those things are going to be large physician multi-specialty groups who can manage those patients and manage the referrals of those patients within those closed networks. So I think over the next 3 years, the MA market is going to go through a period of retrenchment as health plans figure out which markets they want to be in, which products they want to put into those markets, whether HMOs are, again, going to be here to stay. There are downsides to that, I acknowledge, and then figure out how to pay the providers for the plans of care and the models of care that they need in order to manage within a closed network. Again, I think HMOs create winners and losers, back to the point I made earlier. So I do think in the long run, Medicare Advantage is so popular. I mean, people do love their MA plans for good reasons, and for reasons that maybe Medicare fee-for-service is ignored for too long. I'm not a policy person anymore, so I can't really speak to the details of it. But they do tend to seem to like MA. And so there's a market there for it if, again, plans and providers can collaborate in continuing to make it an attractive option for folks who are looking for either transportation benefits, or they're looking for protection from cost sharing, or they're looking, frankly, just for ease of navigation within a network, within a product. Make it easy for me to go see a specialist in a referral. HMOs offer that promise. So we'll see. But I'm optimistic that as we work through the next couple of years of MA retrenchment, we'll get back to a path on growth before too long.
And Erik, when we think about other new models, you'd mentioned concierge care. Yeah, it concerns me a lot. Well, I obviously see the benefit to the doctors who can have less of a workload and make more money. It's very concerning to me that decreasing patient panels is a problem, and that every time a doctor goes concierge, they're abandoning, upwards of 2,000 patients, and primary care access is a huge issue these days. Curious how you see payers adjusting in some ways to allow for doctors to use more ancillary staff, NPs, PAs, but even other, maybe less credentialed staff in technology to manage the populations and somehow get paid for it, and if and what recommendations you're making, right? Because I look at consultants, lawyers, et cetera, and they have a big pyramid underneath them of people, process, technology helping manage, and we don't seem to do a good job of that in primary care. We might do it in surgery or derm or some other specialties, but part of it is because payers insist on only really paying for a doctor seeing a patient, not on their team seeing a patient. So maybe the summary of this is how and why do we get better at paying for team-based care, even if it's in a somewhat of a fee-for-service based scenario versus having to be fully capitated.
Yeah, I share your concern about concierge medicine. for a lot of the reasons that you just described, and for some additional reasons too. Again, I'm not a policy analyst anymore, but from a policy perspective, I think it creates challenges, access challenges being first and foremost. I've been a consultant for a long time, and I try to get smart about different models of professional services to see if there are lessons that I can learn in consulting from lawyers or architects or what have you. What I've learned is there's not a lot I can learn from independent medical practice because it is fundamentally different historically than how some of these pyramid professional services models have come along. And it gets to what you were just describing. We pay for the visit. We don't pay for anything else. And I think that's a problem. And I think that one vector of solutions there is getting the PMPM right. So that per member per month payment that we're paying a primary care doctor actually does explicitly start to acknowledge and pay for the infrastructure that those practices need in order to manage those panels. I don't know if that's doubling the PMPM or tripling the PMPM or increasing it by $1. I haven't done the math on that. But it goes, when we were talking earlier, how do these things fail? One of the reasons these things fail is because we don't price it correctly. I think this is one of the areas where we really need to think through as an industry. We really need to think through, how do we price the PMPM in a way that not only rewards quality and not only rewards access, but rewards the infrastructure that you need to scale this back up. Again, not being a doctor, I don't know whether you can create a compelling enough value proposition to keep physicians out of concierge medicine. I do know that my primary care doc went concierge about, 20 years ago, maybe 15 years ago. Did it for 2 years and got out of it. Didn't like it. And one of the reasons he didn't like it was because the concierge model that he belonged to didn't reward the infrastructure that he needed, which was the whole promise in the first place. So I think the PMPM calculation still largely sits on an average of the number of visits that a patient is going to see in a panel. And that is not the way it needs to work. There are good, really smart actuaries. Again, I tip my cap to my colleagues who are trying to figure this out. But until we start to pay for, it doesn't have to be a pyramid, but until we start to pay for that infrastructure, human capital infrastructure, as well as analytical infrastructure, it's going to be hard to reverse some of this concierge trend.
And like I said, I think the more we can show some of the benefits and the winners, the better is there. I'll ask one final question as we wrap this up, Erik. Where and how can a provider who's thinking about moving more into value-based care, who should they be relying on to help them? What resources are out there, whether it's organizations, publications, who should they talk to at their local payer, et cetera? What's your advice to them?
They should call me. But there's also, I think the advisory board company that is owned by Optum, full disclosure, has done some really good research on value-based care models that work and value-based care models that don't work. Well, definitely worth looking up some of that research. But and you mentioned this, if I were a health system or physician group who's interested in getting into value-based care, and I cannot stress this enough, you need to talk to your local payers. This is as much of a change for payers as it is for providers. And I think if we don't have that level of collaboration, and I recognize that that's overcoming 70 years of antagonism between payers and providers in contract negotiations, but we need to overcome it because it won't work. The care models are one thing, right? I trust the medical community to figure out what care models work best. What I am not sure I trust is that payers are going to pay them for those care models. And until they do, until they pay for the infrastructure and the analytical support and the outcomes in a truly longitudinal way, not a visit way, not a stay way, not an episode way, it's going to be very hard to get this to work in multiple markets. And so as much as I would like to say they should call me, they really should be calling their payers and saying, can we have a different discussion about how we manage the risk of the population that are in your insurance products?
Well, listen, I know we could keep going on this. It's a fascinating and difficult subject, but incredibly important for our healthcare system. Erik, appreciate your time and both your high-level strategy and some specific pragmatic ideas. And we'll wrap up. If people need to find you, I assume you're on LinkedIn.
I'm on LinkedIn. My email is eric.n.johnson@optum.com. Thank you very much for having me today. Really appreciate it. It was a lot of fun. I can talk about this stuff all day, as you can tell.
You bet. So thanks all again. This was the Telehealth and Medicine, today's unscripted podcast series with Erik Johnson. I'm Lyle Berkowitz, and we're going to wrap up.
We appreciate you tuning in to the Telehealth and Medicine Today podcast series. Do you want to learn more or have a comment? Do you have a novel topic or solution to share with our audience? If so, send an email to info@partnersindigitalhealth.com or visit the open access peer-reviewed journal Telehealth and Medicine Today and stay up to date with exciting articles that bridge research with real-world frontline impact. Thanks for listening.